One. Please start, sir. We are live.
Yeah. Good evening, everyone. On behalf of Bayer, I would like to welcome you all for this scientific meeting. So, I will introduce Dr. Sachi Joshi. She is a consultant vitreoretinal surgeon at Surya Eye Institute, Mumbai. After completing her DNB from Shankara Eye Hospital, Shimoga, Karnataka, she went on to pursue fellowship in retina surgery at the pioneer Dr. Nagpal Retina Foundation at Ahmedabad, Gujarat. She honored her surgical knowledge with a fellowship in vitreoretinal surgery from Grant Medical College and Sir J.J. Hospital, Baikula, Mumbai, which is recognized by Maharashtra University of Health Science, Nasik. So I would like to invite Dr. Sachi to give a talk on the diabetic macular edema from understanding to treatment. Yeah, welcome, ma'am. Can we have your presentation, ma'am, please?
The outset, I would like to thank Payer for giving me this opportunity. Are my slide visible?
Yes, ma'am.
Ma'am, full slide mode.
Yeah. Is it
Yeah,
better now?
yeah, ma'am.
Okay. So, warm welcome to all and thank you to Bear and the team for giving me this opportunity. I'll be talking about diabetic macular edema management strategies today. So, during the meeting, I'll just flow through these agenda. Looking at the burden of diabetes, a journey of a patient with diabetic macular edema, and actual diabetic macular edema diagnosis and management strategies. So we are all aware that diabetes is a global burden which is continuously on the rise. If we look at a global burden, there is expected to be a 51% rise in the next 20 years. Southeast Asia is also expected to rise a high number, also along with the rest of the continents, up to 50 to 90% increase in the global burden. And vision loss is the most feared complication of patients with diabetes, along with cardiac, renal, and other circulatory disturbances. So, a vision loss for a patient with diabetic macular edema has unfortunate life-changing consequences, in which they have performing difficulties in performing near vision tasks, reading difficulties, color perception is very faint. Their driving licenses might be revoked, and increased mortality is definitely there. So, in among general population, 8% people have diabetes. Among those who have diabetes, around 35% have diabetic retinopathy, and 7% of them have diabetic macular edema. And out of patients with diabetic macular edema, 40% experience severe visual impairment. So, as we already saw, the principal fear of a person with diabetes is losing their eyesight along with kidneys and other hypoglycemic episodes. Different type of diabetes, as expected, type 1 diabetes is the most common factor which is for the complications of diabetic macular edema, in which 11% people with type 1 diabetes have diabetic macular edema. In type 2 diabetes who are taking insulin, the percentage is around 9, and not taking insulin is also quite high. So a person with diabetes has a lot of comorbidities, including strokes, retinopathy, cardiovascular disease, diabetic kidney disease, dyslipidemia, and neuropathy. Presence of diabetic macular edema is a predictor of cardiovascular mortality and morbidity, in which acute myocardial infarction and cerebrovascular accidents are the most common factors. If we look at the systemic control, each 1% reduction in mean HbA1c reduces the risk of diabetes-related death by 21%, reduces the risk of myocardial infarction by 14%, microvascular complication by 37%, which is a significant number. We are all aware of the basic anatomy and the layers of the retina. So basically, ETDRS defined diabetic macular edema as having retinal thickening within 2 disc diameters from the center of macula. These changes occur because of the compromised blood-retinal barrier, causing leakage of plasma constituents into the retina and consequent retinal edema. If you look at the pathophysiology, hyperglycemia increases the oxidative stress and also reactive oxygen species, advanced glycation end products, polyol pathway activation. All these lead to endothelial dysfunction, leading to retinal ischemia. When there is ischemia, we are all aware that VEGF is increased, insulin-like growth factors are increased, which ultimately lead to increased vascular permeability, causing diabetic macular edema, and also neovascularization, leading to advanced diabetic eye disease. So, a person with diabetic macular edema may see images to be distorted, blurred, there may be dark spot in his vision, in distinct margins. All these can happen. So, risk factors for diabetes, the most important risk factor we are aware is the duration of diabetes and the level of HbA1c. Along with that, high blood pressure and increased total serum cholesterol is associated with an increased risk of heart accidents. There are some genetic factors, and pregnancy is an independent risk factor for diabetes macular edema. So we know how to diagnose this. The basic is the visual acuity testing along with an OCT testing, which is important for diagnosis, management, and follow-up of patients. And in cases we want to stage the disease, fluorescein angiogram is the gold standard. So whenever we approach a patient with diabetes, diabetic macular edema, we have to identify the stage of the disease. We have to look at the modifiable risk factor the person has and refer them to the appropriate physician. As far as an ophthalmologist we are concerned, we have either anti-VEGF agents or laser or steroid injections at our disposal. So some of the medicines that are available in the market that we use commonly, bevacizumab is a full-length antibody, which is a off-label use for diabetic macular edema. It was basically, we are aware it was meant for oncology indications, and right now it is not licensed for ophthalmic administration. Ranibizumab was specifically designed for intraocular use. It is a monoclonal antibody fragment with maximum biological activity while minimizing systemic exposure. It has a very favorable systemic safety profile and it is approved for DME. It inhibits the action of VEGF-A in the retina. Coming to aflibercept, aflibercept is also an anti-VEGF-A placental growth factor, VEGF-B recombinant fusion protein, which contains the Fc portion of IgG. It was also initially developed for oncology use. Along with that, we have some steroid at our disposal, including dexamethasone implant, also called as Ozurdex. It is a long-acting, sustained-release, biodegradable corticosteroid, which stays in the vitreous cavity for a period of up to 6 months, releasing the drug. All the steroid medications have a potential IOP rise and cataract formation as a side effect. So, how to approach a patient with diabetic macular edema? This flowchart summarizes it. So, whenever we see a diabetic macular edema, the first thing that we look at is the vision. If there is no vision loss and center is involved, we can still observe the patient. If it is a non-center involved diabetic macular edema, we can do laser to the leaky microaneurysms or grid laser. If the person with diabetic macular edema has a vision loss, if the vision loss has a focal macular edema, then first line treatment is anti-VEGF. Second line can be laser. If the person has diffuse macular edema and high cardiovascular risk, person is pseudophakic, then we have to offer them steroids along with second line anti-VEGF drugs. If the person doesn't have any cardiovascular risk, is phakic, first line is still anti-VEGFs and steroids. If the diabetic macular edema is tractional, the first line is vitreous surgery along with steroids. How to prevent diabetic macular edema? We know that strict adherence to a prescription by a doctor is very important. Healthy lifestyle and weight maintenance, physical activity addition to your day, controlling ABCs, that is HbA1c, blood pressure and cholesterol, and quitting of smoking. So we saw that loss of vision is the most feared complication of diabetes. Diabetic macular edema is the most common cause of visual impairment in patients with diabetes. DME unfortunately affects the working population and therefore requires long-term management. And patients with diabetes are at increased risk of several comorbid and chronic conditions, which further aggravates in patients with diabetic macular edema. If you look at few comparisons, then we read gaining 1 line, 2 line in a lot of studies that. How does it translate clinically? If a patient gains 1 line, they may be able to read newspaper or drive at night. Gaining 2 lines after a treatment may give them better near vision or better ability to perform near functions. And 3 lines may improve their color perceptions. All this can help the patients to maintain their driver license, reduce risk of mental illness as compared to, and have a dramatic impact on the patient's daily lifestyle. So if you look at the pathophysiology, VEGF and placental growth factor both drive the development of retinal vascular diseases. When there is impaired retinal blood flow, hypoxia causes these two molecules to adhere to the VEGF receptor and increase the permeability and cause pericyte loss and opening of tight junction, leading to diabetic macular edema, vascular leakage, and new vessel formation. So we have to see that even if our agent blocks VEGF completely, placental growth factor will still be available to bind to the receptor and then cause all inflammation. So we need a strategy which can effectively bind with both VEGF and placental growth factor. Aflibercept has been designed to specifically bind to VEGF receptor 1 and 2 and has the strongest reported anti-VEGF binding affinity among the following approved agents. So, aflibercept is the only one which blocks both VEGF-A and placental growth factor. Ranibizumab blocks only VEGF-A. Romlusuzumab also blocks VEGF-A. Faricimab is the one which has some hands-to action. Bevacizumab, which is an off-label in use, also blocks only VEGF-A. Aflibercept is the only globally available molecule which blocks both the pathways. Aflibercept is also the standard of care in diabetic macular edema and is studied in the large DRCR retina.net studies. In protocol W, protocol T, various studies have shown the efficacy of it. In protocol T, rapid vision gains were achieved with early intensive treatment, and aflibercept demonstrated advantages over ranibizumab and bevacizumab at 2 years of treatment in regardless of patient baseline vision acuity. In Violet trials, vision gains were maintained or increased in the long term with a low treatment burden. Jade trial significantly showed that majority of patients can reach treatment interval of up to 12 weeks at 1 year with proactive treat and extend regimen with aflibercept. Aflibercept provides excellent safety profile across multiple indications. So it is indicated for licensed in 6 indications, including diabetic macular edema, neovascular AMD, CRVOs, BRVOs, myopic CNVMs, and neovascular glaucoma. They have more than a decade of clinical trials and post-marketing experience. Also, they have excellent safety profile in which the rate of IOI is very low, 1 in 10,000 cases, and endophthalmitis, which is the most feared complication, is quite low at 0.6. So to summarize, VEGF anti-aflibercept can achieve clinically meaningful vision gains and maintain vision regardless of baseline vision, and is a treatment of choice with baseline vision acuity of less than 69 letters. Aflibercept is the only bispecific VEGF fusion protein that is designed to trap VEGF and placental growth factor. So early intensive treatment initiated can maximize vision gain, and they can be maintained over a long term with a reduced treatment burden. Emerging real-world studies in DME have shown that it leads to good visual and anatomical outcomes in clinical practice that are consistent with those which are reported in the clinical trials. Thank you.
Yeah. Thank you, Sachi ma'am, for your wonderful talk. So, ma'am, you can unshare your screen. By the time, I'd like to invite Dr. Mayur Rokde sir to give his introduction. He's a vitreoretinal specialist and director of Chaitanya Eye Care and Retina Center, Indore. He has completed his MBBS from MGM Medical College, Indore, and further pursued his DNB and fellowship in vitreoretinal surgery from the prestigious Arvind Eye Hospital, Coimbatore. He also holds the internationally recognized FICO UK certification. Dr. Rokde has been actively involved in advanced retinal research and innovation. He was a part of Smart India Study Group, a multinational and a multi-centric project conducted in collaboration with Google, focusing on linking diabetic retinopathy screening with AI-assisted fundus camera technology. With expertise in medical and surgical retina, Dr. Rokde is dedicated to delivering advanced retinal care with strong emphasis on innovation, precision, and patient-centered treatment. So with this, I would like to invite Dr. Mayur Rokde sir for giving a talk on NAMD and critical information for the clinicians to enhance patient outcomes. Sir, please.
Thank you, Pratik ji. I'll just share my screen.
Yeah.
My slides visible?
Sir, it's just sharing. Yeah, now it's visible. You can put it on screen mode, slideshow.
All good?
Yeah, now it's slideshow, sir. Yeah, we can go in. Thank you.
So thank you, Pratik ji, and thank you, Bayer, for providing me this platform. I'll be discussing some critical info that the clinicians should know. Nowadays, we have so many RCTs and real-world evidences. So I'm just going to talk about few of them and what how aflibercept plays a role in the treatment of NAMD and what we should know. These are my disclaimers and a full financial disclosure. So, in approximately 8.2 billion world population, around 200 million have been diagnosed with AMD, and that number is projected to increase to up to around 300 million in 2040. And as the world prevalence of AMD increases, India does not remain far behind. Our 0.54 to 0.67% of the population has already been diagnosed with AMD, and it is supposed to increase only. It's not going to go down. The initial symptoms include blurring of central vision, visual distortion such as straight lines appearing bent, central or a paracentral scotoma, and a general haziness in overall vision. You can see the difference between the initial visual symptoms and the worsening visual symptoms in this slide. The stages are quite clearly defined nowadays. Early intermediate AMD, in which there are few to no changes in central vision. Only the size, mostly the size of the drusen causes the differentiation in the stages. When we move to the late stages of AMD, they can be divided into atrophic, dry AMD, or geographical atrophy, and neovascular AMD, which was also known as wet AMD. This is the most aggressive form of AMD, often leading to rapid loss of central vision, and hence we are going to talk about NAMD today. So the diagnosis of AMD is multimodal, starting from your standard eye charting, your home Amsler grid monitoring, retinal exam, regular retinal examination, FFA and ICG, and of course OCT, and now OCT angio also. The key which we have to remember, the key for this talk is that time lost is vision loss. So our goal is to reduce the treatment burden, and our goal is to give the best of all the worlds, clinical, practical, and financial, to the patient. That's our responsibility as clinicians. Since we all know, if left untreated, it can lead to permanent loss of vision symptoms. So the correct timing and correct treatment at the correct time is the most important thing. So what factors drive key mechanisms behind the pathogenesis? There's VEGF-A, there's VEGF-A and PIGF, placental growth factor. VEGF-A acts directly over VEGF receptor 1 and 2, and PIGF acts directly over VEGF receptor 1 and indirectly over VEGF receptor 2 by displacing VEGF-A from the receptor 1. Apart from that, heterodimers of VEGF-A and PIGF can also induce and activate these receptors. So excessive activation of these receptors can result in increased vascular leakage, subsequent edema, inflammation, pathological neovascularization, and in the end, scarring. Among the globally available molecules, we can see that aflibercept is the only available anti-VEGF agent that targets multiple mediators of the retinal disease. Brolucizumab targets VEGF-A, ranibizumab targets VEGF-A. I'm not going to talk about bevacizumab. So here you can see that VEGF-A, B, and PIGF all have been targeted by aflibercept. In a tabular comparison, you can see that the VEGF binding affinity, the estimated human half-life in days, number of targets, and potency, or in all those categories, aflibercept takes the cake. So why should we consider aflibercept as a choice of anti-VEGFs in wet AMD? We'll have a look at few RCTs and few real-world evidence studies. The ALTAIR was a multi-center randomized open-label study targeted at treatment-naive NAMD patients. So they had two distinctions: a 2-week treat and extend regimen and a 4-week treat and extend interval. At 52 weeks, which was the primary endpoint, and at 96 weeks, which was the study endpoint, we can see that both the groups show a similar pattern in the mean change of BCVA, as well as mean number of injections at week 52, 7.2 in the 2-week group and 6.9 in the 4-week group. As we progress and come to the endpoint, and I will come to the endpoint of the study, you can see that they have similar number of injections through week 96 and a similar mean change in the BCVA from the baseline. So I can say that from this slide, we can easily infer that aflibercept has demonstrated durability when it comes to proactive treat and extend regimen. Also, approximately 60% of the total patients could be increased to Q12 regimen, and 46% of the total number of patients they were able to increase them up to Q16 dosing at the end of 2 years. So that's a very promising sign. In this graphic, you can see the number of patients who had achieved total number of patients who had achieved uh, Q16 interval, and those out of the achievers who could maintain the Q16 regimen. So in all, it up to 96.2% of the patients who had achieved Q16, they were able to maintain that over a period of 5 years, which we can see from this graphic. The View 1 study, which was which showed that the visual gains which were achieved at the end of 2 years, they could approximately be traced as far as 4 years. And another extension of the View 1 study was the range study. So that range study also demonstrated that the visual mean BCVA change from View 1 was able to be maintained at up to 5 years uh, 5 years from the beginning. Now coming to the real world evidence of NAMD, a study conducted by Fighting Retinal Blindness Registry showed that treat and extend regimen achieved good visual gains with the reduction in treatment burden in the second year. They showed a mean number of injections with aflibercept of approximately of 13.6, and by end of year 2, they showed that 24% of the eyes involved in the study being treated were able to achieve Q12 or more. Another study conducted by Lukic et al. From Moorfields, they demonstrated that the mean number of injections kept on decreasing over each year, and by the end of 2 years, they were able to corroborate the Altair study's finding that 52.8% of the eyes were able to achieve an interval of Q12 and beyond. Jaggi et al. Study from 2020 corroborated once more that their median injection interval was 11 weeks, which was close to Q12 as achieved by Altair study. Additionally, they were able to demonstrate that 35% of their patients met the exit criteria, and they had their therapy terminated after 2.6 years. So this is a graphic which compares the real world evidence with the RCTs, and on the left side we can see that treat and extend is slightly better, although not clinically, although not statistically significant, but treat and extend is still slightly better when it comes to the number of injections and the mean BCVA change. Another subtype of NAMD is PCV, and it is by far the most prevalent subtype of NMD in Asian population. Although it may be underdiagnosed in Caucasian populations, but Asians and specifically the Oriental population suffers a lot from PCV. So coming to an RCT, the PLANET study, it was a double mass sham control prospective multicentral study. They had enrolled 318 patients, and they had compared the efficacy of aflibercept monotherapy against aflibercept plus active PDT for treatments of patients with PCV. They had two endpoints, the primary endpoint and the study endpoint. Primary endpoint was at week 52. They compared aflibercept Q4 as after initial 3 monthly doses. At week 12, there was a equal randomization, and the patients were divided into aflibercept Q8 monotherapy or rescue treatment, which was defined as aflibercept Q4 plus sham PDT. In the other group, it was Q4 plus active PDT. The rest of the things remained the same. Another randomization occurred after week 52 with similar parameters. So what they found out was at the end of year 1 and year 2, with year 1 constituting Q8 dosing and year 2 constituting optional dosing, both the groups, aflibercept monotherapy versus aflibercept and active rescue PDT, showed similar same mean BCVA change from baseline, which became slightly better in the monotherapy group at the end of 2 years, and they had almost equal number of injections in both the groups. So from this, we can infer that the aflibercept monotherapy achieves a clinically meaningful visual outcome in at least PCV. So if we try and do an indirect comparison to Everest study, which compared ranibizumab monotherapy against ranibizumab with mandatory PDT, in which the combined therapy had turned out to be superior to monotherapy. In this case, we can clearly see that aflibercept monotherapy is absolutely non-inferior and similar in efficacy to combined therapy. This is another graphic which shows that patients in both the arms, more than 80% of the patients showed no evidence of active polyps, which was defined by doing indocyanine green angiography. So on either it should have shown up as no polyps or polyps with no new or persistent fluid on OCT. So we can see both the arms performed equally well with more than 80% resolution of active polyps. These are some other examples of real-world studies, mostly Japanese studies, against RCTs, which such as View 2, Vault, Apollo, and Planet. You can see that they corroborate directly. Another graphic which shows that polyp regression also follows the same pattern as mean BCVA change in both RCTs and real-world evidence studies. No talk would be complete without highlighting the safety profile of aflibercept. You can clearly see there's a stark difference between the retinal vasculitis and occlusive retinal vasculitis rates per 10,000 in aflibercept and the other two molecules which are available in the market for treatment of NMD and PCV. Dr. Shachi has already covered this slide very well. Very low rate of intraocular inflammation, very low rate of endophthalmitis, more than 62 million doses, more than a decade of efficacy and safety, which has been provided by aflibercept. So my take-home messages will be early intervention is decisive. Comprehensive inhibition, which currently only aflibercept is providing with broad spectrum blockade of VEGF-A and PIGF, is the key. Altair shows that there is proven durability. Planet study shows that even monotherapy gives a superior PCV management and sustained real-world success, which you have seen through all the graphics, is clearly present with aflibercept. So these are my take-home messages, and thank you for your time. Have a good night.
Yeah. Thank you, Mayur sir, for a wonderful talk. Once again, I would like to thank Mayur sir and Dr. Shachi ma'am for giving a wonderful talk. So we just wait for 1 or 2 minutes, sir. If we have any questions in the chat. Yeah. I guess no questions, sir. Sir, if you would like to comment on any of the things you would like to comment, if Dr. Sachi ma'am would like to comment.
No, definitely, it has been a good experience with this molecule with absolute safety and efficacy every time. So this molecule never disappoints. In AMD and even across all the indications, definitely the molecule of choice.
Yeah, great, ma'am. Thanks for a belief in Eylea, ma'am, and thanks for the support. So yeah, anything else, sir? Mayur sir, if you would like to highlight.
Ma'am has said everything, and trust and that predictability and repeatability is very important. And
Yeah.
even with so many other options, yes, I'm still going with Eylea just because of those three things. And patients are also happy, so no complaints there.
Great, sir. Great.
Thank you.
Thank you. Once again, I would like to thank all the participants, those who have spared their valuable time to join this meeting. Thank you. Thank you. Good night.
Thank you to you
Thank
as
you.
well.
Good night. Good
for all
night. Thank you.
participants.